The third lesson under cardiovascular pharmacology talks about the drugs for heart failure. In this regard, the agents that can be used in the management of a particular cardiac condition will be discussed. And that is yung mga anti-heart failure agents. Now, I've decided to divide our lesson here into three major parts, starting on control of the normal cardiac contractility. Then it will be followed by the ejection fraction, and finally, discussing heart failure, okay, as a condition. And under heart failure, we will be discussing the different types of heart failure and the compensatory mechanisms on how the heart tries to correct what is wrong, how the heart tries to correct the problem during heart failure. And also, we will study the different classifications based on the guidelines established by different associations. Then, of course, finally, we will study the goals and the management of this condition. And finally, the anti-heart failure drugs. So first up, let us begin discussing the control of normal cardiac contractility. This concept is very important. This is very important for you to understand the action later on of drugs. So, in this regard, I will discuss how is the normal cardiac myocytes contracts and relaxes. So, explain na ako dire na illustration. Okay? Paano yung normal cardiac contractility, paano yung normal contraction and then relax, pump, then dilate, pump, then relax. Okay? Now, in order for you to understand this, I will divide the figure into two segments. Okay, divide natin yung figure into two segments. Wherein, on the left side, okay, sa left side, this is all about contraction. Okay, sa left side, that is all about contraction. Uh, Particularly, contraction ng, of course, myocardial smooth muscles, yung myocardial fibrils. And then on the right side, we will talk here the normal relaxation ng cardiac fibrils. Okay? So, start tayo sa cardiac contraction. Sa cardiac contraction, there are distinct areas that should be noted. Una, in the T-tubule, we have areas like the L-type calcium channel. Okay? So, we have here the L-type calcium channel. So, ito yung L-type calcium channel. Ayan. Okay? So, somehow, you have already an idea what is the function of L-type calcium channel. Halos gabalik-balik lang yun. 'Di ba? Ang concepts sa cardiovascular pharmacology. Okay, but maybe ang inyuhang nadumduman about the L-type calcium channel is may kinalaman sa arteriolar smooth muscles lang. Okay? Now dito sa heart na. Okay? Sa heart na yung tinutukoy natin na L-type calcium channel. Kung naaalala nyo, yung L-type calcium channel, sabi ko, 'di ba, na meron tayong calcium channel na nasa heart, cardiac, meron din sa mga smooth muscle blood vessels. Kaya, meron tayong calcium channel blockers that are cardiac acting, meron din na vaso-selective na calcium channel blockers. Okay, so dito, okay, this particular calcium channel is an L-type calcium channel of the heart. Okay, also on the left side, Also on the left side, we have here the SR or the sarcoplasmic reticulum. Okay? Of course, yung SR that contains the calcium channel. Ito naman yung calcium channel. Okay? Kaning naay mura gate. Okay, sa SR, yan yung calcium channel. Particularly, this is known as ryanodine receptor channel. Again, that is particularly known as ryanodine receptor channel. And we have here sa baba, kaning nasa baba on the left side, ito naman yung actin myosin complex. Yan yung actin myosin complex that waits for the calcium signal for them to contract. Okay? For them to contract. So how this happens? How does this happen? Paano yung normal cardiac contraction? So first up, just like before, in arteriolar smooth muscles, we have here the calcium ion trigger. Naalala? 'Di ba? Pag yung diniscuss ko yung L-type calcium channel, may na-mention akong trigger, calcium. So, same lang din dito sa heart, sa cardiac myocyte. Okay? Since may L-type calcium channel, this allows entry of calcium ion trigger. Okay? So, the calcium ion here, ayan, it will enter through the L-type calcium channel. And such entry of the trigger, okay, or such entry of that calcium ion trigger that causes activation of the ryanodine receptor channel. Okay? Again, such entry of the trigger calcium via the L-type calcium channel that causes activation of the ryanodine receptor channel in the SR. And of course, when activated, itong mga sequestered na mga calcium ions inside the SR, it will move outside. So, matitrigger yung paglabas nila. Kaya ang effect ng paglabas ng calcium ion from the SR, tataas, di ba? Yung calcium ion or calcium level dito sa loob ng cytoplasm kasi nagsilabasan yung mga sequestered calcium ion inside the SR. And such increase of this calcium ion in the cytoplasm that causes, of course, contraction ultimately. Okay? Yung final result talaga is contraction. Okay? So, okay na tayo sa contraction. So, yan yung normal na nangyayari pag nag-pump, pag nag-contract yung heart, yung cardiac myocyte. What about in the relaxation? Okay? Siyempre, yung heart, di ba, mag-contract, then relax. Sa relaxation naman, sa relaxation portion, on the right side, ang goal, syempre, is to lessen the amount of calcium ion inside the cytoplasm. Okay? Kasi pag mayroong calcium ion sa cytoplasm, maraming calcium ion sa cytoplasm, end result, ultimately, is contraction. So, ang goal for relaxation naman is to lessen the amount of calcium ion inside the cytoplasm. Okay? Kasi nga again, kapag mababa ang calcium ion sa cytoplasm, it is realized na magre-relax ang cardiac myocyte. Okay, so ano yung mga pwedeng mangyari during relaxation? Ano yung pwedeng mangyari during relaxation? Please note na meron tayong dalawang mechanisms para ma-facilitate ang relaxation. Okay? Or yung pag-relax or pagbaba ng calcium ion sa cytoplasm. So, number one is that ang excess calcium ion Okay, in the cytoplasm, syempre may excess calcium ion. Okay, upon contraction, di ba, may excess calcium ion inside the cytoplasm. Na so unang mechanism para mag-relax, yung mga excess calcium ion inside the cytoplasm uh, will go back. It will go back inside the sarcoplasmic reticulum. Again, yung excess calcium ion, babalik. It will return inside the sarcoplasmic reticulum. So kapag bumalik sila sa sarcoplasmic reticulum, of course, bababa. 'Di ba? Bababa ang level ng calcium ion sa cytoplasm. Bababa ang cytoplasmic calcium ion. Again, bababa yung cytoplasmic calcium ion. So kapag bababa ang cytoplasmic calcium ion, lesser ang contraction. So ultimately, that will cause relaxation. Okay? Now, paano naman yung pagbalik? Paano yung pagbalik ng calcium ion mula dito sa cytoplasm papuntang sarcoplasmic reticulum? Okay, this happens via this receptor. Okay? Again, yung pagbalik ng calcium ion mula cytoplasm into sarcoplasmic reticulum, that is via the transporter found in sarcoplasmic reticulum, which allows entry of calcium ion into it. Ang tawag dyan sa transporter na naa sa sarcoplasmic reticulum is SERCA. Okay, SERCA ang tawag sa transporter na yan. This is called SERCA. SERCA stands for sarcoplasmic endoplasmic reticulum calcium ATPase. Again, SERCA stands for sarcoplasmic endoplasmic reticulum calcium ATPase. Okay, so that is for the first mechanism. Okay, susulat ko ha, yan yung first mechanism, SERCA. Okay, via SERCA. Yung mga excess calcium ion sa cytoplasm babalik sa sarcoplasmic reticulum via SERCA, resulting to cardiac relaxation. And then, for the second mechanism, may kinalaman naman ito sa calcium extrusion. Okay? Again, yung second mechanism ng cardiac relaxation, may kinalaman naman ito sa calcium extrusion through the sodium-potassium ATPase pump. Okay? Again, sa second mechanism, of cardiac relaxation, this is related to calcium ion extrusion. Okay? Calcium ion extrusion. Ayan. Okay, via the action of the sodium-potassium ATPase pump. Somehow, naan mo'y idea about calcium ion extrusion happening via this carrier molecule. Diba? Naalala ba yung sodium-potassium ATPase pump? Na-introduce na ako ni siya sa lecture 1 under sa review. Diba? If nakadumdum pa mo. So, the sodium-potassium ATPase pump, it is found here. I-zoom sana ako. Kana siya. Okay, so muna siya. Ang sodium-potassium ATPase pump, isang carrier molecule found in the cardiac myocyte. Okay, so as the name of the pump suggests, diba, sa pump exchanger. So sodium, it suggests a sodium-potassium exchange. Particularly, there is inward of potassium ions, okay, specifically two ions of potassium gets in. Okay, it enters the cell in exchange of dito ko ilagay, 3 sodium ions. Okay? Again, yung sodium-potassium ATPase pump, okay, nagkakaroon dyan ng inward current of potassium ion, yung 2 ions of potassium, okay, it will enter. Then yung 3 sodium ions, it will go outside. Okay? Now take note na once yung sodium-potassium ATPase pump is being activated, once yung sodium-potassium ATPase pump ma-stimulate, ma-activate, that eventually causes activation of another pump. Okay, another pump. And this pump is called as, kani siya, that is called as NCX. Okay, NCX. Okay, again, upon activation of sodium-potassium ATPase pump, okay, that eventually causes activation of another pump. Okay, and that is the NCX. Okay, NCX. Okay, NCX stands for sodium calcium exchanger. Sodium calcium exchanger. So as the term suggests, it allows exchange of sodium ions and calcium ions in such a way na katong sodium ion na lumabas kanina, okay, via the sodium potassium ATPase, babalik siya. Babalik siya into the cardiac myocyte. So, papasok ulit ang isang sodium ion in exchange of a calcium ion. Okay? So, taken all together, kapag na-activate ang sodium-potassium ATPase, ma-activate yung NCX. Kaya, ang calcium ion ay lalabas. Okay? That's why with NCX, sodium potassium ATPase, end result, there is calcium extrusion. Palabas yung calcium ion. Nagkakaroon ng calcium extrusion. Nabawasan, kumbaga, yung calcium ion inside the cytoplasm, inside the cardiac myocyte. Siyempre, kapag nabawasan ang calcium ion inside the cell, di ba yan yung goal natin for cardiac relaxation? Bawasan, okay? I-lessen ang calcium ion sa cardiac myocyte. So that, with that, we suppose na magre-relax ang cardiac smooth muscles. Okay, so yan yung normal mechanism of cardiac contraction and relaxation. Okay? So, I repeat, this is very important Very important ni siya para maintindihan yung mga actions ng drugs later. Okay? So, ayaw ninyo limte ang ryanodine, okay? Yung L-type, calcium channel, yung SR, okay? Yung SERCA, ayaw kalimte, yung transporter, okay? Na makita sa SR para makasulod balik yung calcium. Ayun, tsaka yung sodium potassium ATPase pump. Okay, very important for calcium ion extrusion. Now, another concept also important in this topic is the ejection fraction. Ejection fraction, this tells us about or something about how much of the blood is being ejected. Okay? How much of the blood is being ejected by the heart. Okay? In particular, we can compute ejection fraction by dividing the amount of blood pumped out by the ventricle and also the total amount of the blood that was accepted by it. Okay? In other words, kapag ejection fraction, inaalam natin yung ratio ng stroke volume at cardiac preload. Okay? Ratio ng stroke volume at ng cardiac preload. Okay? So when we talk about stroke volume, recall natin yung stroke volume, 'di ba? Ito yung amount ng blood, volume of the blood ejected or pumped out by the heart per beat or per contraction. Okay, yan yung stroke volume, 'di ba? Volume, stroke, then volume. Volume ng blood per stroke, so per contract. Okay? Kapag preload naman, that is the amount of the blood that was accepted by the heart. Or yung mismong blood that was returned by the veins. Yung venous return. Di ba? Yan yung cardiac preload. That's why we can have this sample illustration for better understanding on ejection fraction. Okay? So, meron tayong, for this for this illustration shown, okay, remember again, yung stroke volume, di ba? Ang stroke volume, it tells something about amount ng blood na inilabas ng puso, being pumped out by the heart. Okay, so inilabas ng puso. And then, kapag naman end diastolic volume, di ba? That is yung preload. Tama? Yung preload. Okay, another name, venous return, and diastolic volume. Yung amount na tinanggap ng puso coming from the veins. Okay? So with this being said, kapag sinabing ejection fraction, okay, ejection fraction, mauni siya ang pasabot sa dami ng dugo na tinanggap ng puso, sa dami ng na-receive niya, gaano karami eventually ang nailabas niya later on. Okay? So, gaano karami ang nilabas out of sa natanggap. Okay? So, unsa kadaghan ang gi-eject, okay, out of sa gidawat ng puso, ng heart. Okay? So, yan yung ibig sabihin ng ejection fraction. So, ratio gid siya ni stroke volume over the preload. Now, may mga interpretation tayo sa mga values ng ejection. Okay? Meron tayong interpretation sa mga values ng ejection fraction na na-calculate. Okay? For example, kapag ang ejection fraction ranges from 50 to 65%, example, sample lang, hypothetical. Out of 100 ml out of 100 ml na natanggap ng puso. Okay, ito yung tinanggap ng puso na blood. Out of 100 ml na natanggap ng puso, ang value na nailabas, okay, na inilabas ng puso is maaaring 50 to 65 ml. Okay? Kaya di ba, syempre 100 ml, iyang 50 to 65% is 50 to 65 ml. Okay? So kapag 50 to 65 ml ang nailabas ng puso out of 100 ml na natanggap, okay? So ito na yung natanggap ng puso. Ito yung heart. Okay? Natanggap 100 ml, nailabas 50 to 65 ml. Normal daw yan na value. Okay, ito yung interpretation sa ejection fraction. Pero hypothetical yung example ko yung example ko na 100 ml, hypothetical. Example lang na siya para masabtan yung percentage. Okay? Pero kapag naman 36 out of 100 ml, tapos ang nailabas ng puso is 36 to 49 ml lang, that is below normal. And kapag low, 35%. Kapag low, 35%. So, ano yung implication kapag ang amount ng ejection fraction is only 35%? Ano yung ibig sabihin? Meaning, syempre, ang ibig sabihin yan, konti lang yung nailabas ng puso. 'Di ba? Kasi very low yung ejection fraction niya. Kasi 35 ml lang daw, pababa, 'di ba? So, kung konti lang, okay, kung konti lang yung nailabas, kumusta naman ngayon ang natirang dugo sa puso? Okay, say for example, konti lang yung nailabas, so 35 ml. Kumusta ngayon yung natirang dugo sa puso? Marami ba yung naiwan, do you think? Or konti din yung naiwan? Konti lang daw yung nailabas. Okay? What do you think? Marami ba yung naiwan or konti? Yung naiwan ha, yung naiwan sa puso. Marami or konti? Marami. Okay? Marami yung natira sa puso. Okay? So, kung konti yung nailabas, konti lang yung nailabas, na ilalabas ng puso, marami yung naiiwan. Okay? Siyempre, may parating, di ba, ulit na dugo. Okay? May parating ulit na dugo. And then, konti na naman yung nailabas niya. May parating ulit na dugo. Di ba? Upon relaxation, may parating ulit na dugo. Konti na naman yung na-eject ng puso. Okay? Then, parating ulit. Okay? So, the cycle repeats and konti lang yung inilalabas, yung ejection fraction niya. Time will come, wherein magkakaroon ng excess, okay, or masyadong mataas ang amount ng volume ng blood na naiiwan dito sa puso. Until such time na maaari itong mag-cause ng backflow, okay, sa different areas or tissues. Yes, pwedeng mo backflow ang mga na-receive na dugo ng heart, pwede siyang mo backflow sa different areas or tissue. So, dyan magkakaroon ng mga complications. Particularly, dyan magkakaroon ng tinatawag nating heart failure. Okay? So, si heart failure, it is actually a proof that the heart is not functioning well already. Okay? So, heart failure nga, di ba? Obvious naman sa iyahang term. Okay? This is defined as progressive. I-highlight ninyo ang progressive, ha? Progressive inability of the heart to supply adequate blood to vital organs. Okay? And that's why ang tawag ay heart failure because the heart really fails to meet the demands of the peripheral systems. Siyempre, yung mga peripheral tissues natin, nangangailangan yan ng oxygenated blood. Dayon ang imong heart, dili kaayo maglabas, mag-pump out ng enough blood. Okay? Na kailangan ng mga peripheral tissue. So, hindi niya na-meet, nag-give yung demands ng mga peripheral system. So, yung heart really fails to do its job. Okay? Remember ha, nasabi ko during sa hypertension na introduction, ang mga peripheral systems sa different organs and tissues in the body, they need oxygen, they need nutrients for efficient metabolism. So, yun na nga, since ang problema is yung heart does not pump efficiently or the heart does not pump well, kukonte ang natatanggap ng oxygen ng different organs in the body. Kaya posibleng magkaroon ng complication. So, ang task, ang job ng heart, bagsak or failed. Okay? And this is an impairment of the heart's ability to fill or to empty, di ba? The ventricle properly. Nag-fail daw siya to empty. So, nag-fail siya to pump out. Di ba? Nag-fail siya to fill. Okay? Kasi nga, nagkakaroon ng heart failure. Okay, failing na yung heart. So, very related talaga yung concept na to sa ejection fraction. Kasi, again, sa ejection fraction, konti lang yung nailalabas, basta may heart failure ha, konti lang yung nailalabas out of sa natanggap ng puso. So, failing ang puso. Okay? Now, in general, ang heart failure, this is a complex of symptoms that are related to inadequate perfusion ng tissues during exertion or often retention of fluids. But we have this so-called cardinal symptoms of heart failure in which kahit na diverse ang mga symptoms ng heart failure, common yung tatlong ito. Okay? Ito yung usual na napapansin natin sa taong may heart failure. Okay? So, number 1 is dyspnea. Okay? Dyspnea, this is difficulty of breathing. Dyspnea, ito yung difficulty of breathing. So, marami tayong mga possible presentation ng dyspnea kapag ang patient ay may heart failure. Okay? Daganta klase ha nga dyspnea. Okay? Okay. So, example ng mga possible presentation ng dyspnea kapag may heart failure yung pasyente is yung dyspnea upon exertion. Okay? So, una, yung dyspnea upon exertion. So, ibig sabihin, ng dyspnea upon exertion kapag ang patient ay nag-e-exert ng effort, okay? Or nag-engage sa mga physical activities. This difficulty of breathing or dyspnea is being felt by the patient with heart failure. So, upon exertion ng effort, upon engagement to physical activities. Okay? So, dyan niya matagamtaman ang symptom na dyspnea. Another possible presentation ng dyspnea is orthopnea. Okay? Orthopnea. Okay? Ang orthopnea naman ay kapag ang patient is nakahiga. Nakahiga, nararamdaman niya yung hirap sa paghinga. Okay? Or difficulty in breathing when lying flat in bed. Okay? So, yan yung orthopnea, difficulty in breathing when lying flat in bed. And also, naapod tay ginatawag na paroxysmal nocturnal dyspnea. Okay? Paroxysmal nocturnal dyspnea. Okay? Ito naman, ang problem dito is when the patient is sleeping. Okay? Bigla siyang nagigising kasi hirap siyang huminga. Okay? Kaya siya paroxysmal. Okay? Paroxysmal, ibig sabihin kasi ng paroxysmal is sudden or biglaan. So, sudden difficulty of breathing that awakens the patient at night while sleeping. So, yan yung paroxysmal ha, na nocturnal dyspnea. Sudden difficulty of breathing that awakens the patient while asleep. Okay? So, yan yung mga posibleng presentations ng dyspnea if the patient has heart failure. Okay? Then, we have edema. Okay? Edema, of course, edema usually happens because of accumulation of blood in the heart. Okay? So, malaki talaga yung chance of backflowing. Okay? So, meron tayong dalawang common presentations of edema kapag ang patient mayroong heart failure. Pwede siyang magkaroon ng peripheral edema, or kaya naman pulmonary edema. Okay? Sa peripheral edema, The extremities are edematous. So, yung mga peripheral tissues, sila yung affected. Okay, yung mga lower, upper extremities, okay, like yung hita, yung bente, okay, yung hips. So, yan yung mga edematous part kapag peripheral edema. And usually, ang peripheral edema, this is related. Related siya when the right ventricle fails to do its job. Okay? When the right ventricle failed to do its job. Okay? So again, common ni siya sa right-sided na failure. Right-sided na failure. So, ang right ventricle ay mahina, kumbaga, mag-pump. Okay? Mahina mag-pump yung right ventricle. Kaya nagba-backflow ang blood into the periphery. Somehow, related siya sa systemic circulation, yung the one I had discussed before, katong about sa circuitry of systemic circulation. Balikan niyo lang yung illustration na yan. Check niyo yung right ventricle. Hanapin niyo yung right ventricle. Then imagine niyo yung function ng right ventricle failing. Okay? So, syempre, papunta talaga, pabalik sa peripheral tissues, sa periphery. Okay? Kapag pulmonary edema naman, left-sided failure naman. Left-sided failure wherein the left ventricles naman yung affected. So that's for edema. And heart failure, take note, heart failure good, yun yung dumdumon, heart failure that is always accompanied by edema. Edematous good nga case ang heart failure. That is why in other references, 'di ba, ang other nga condition nga ginatawag basta heart failure that is also referred to as congestive heart failure or CHF. Okay, so it is termed as congestive heart failure because of the accumulation of fluids. Okay, there is already congestion. Diba? Dahil sa accumulation ng fluids, nagkakaroon ng congestion or pagbabara in certain areas of the body. Okay, kaya tinawag siya ang congestive heart failure din. Okay. Next, for this slide, okay, kanya siya, it differentiates the two types of heart failure. So we have diastolic and systolic heart failure. So I believe meron na kayong idea sa terms na diastolic and systolic. Recall na kapag diastolic, 'di ba, ito yung ventricular relaxation or contraction. Ito yung relaxation of the heart. Therefore, kapag diastolic heart failure, the ventricles here do not relax properly. Okay? So, feeling yung diastole. Okay? Na activity ng heart. It fails to relax efficiently. Kapag naman systolic, di ba? Systolic, yan yung ventricular contraction. That is very important, yung systolic. Yung systole, ventricular contraction. Kasi very important siya para ma-pump out yung oxygenated blood. So, kapag systolic heart failure, ang left ventricle of the heart, okay, doesn't contract. Okay? It doesn't contract efficiently or it doesn't contract with enough force. Okay? So, yan yung nangyayari. Okay? So, just take a note of the characteristics, yung differences ng two major types ng heart failure na to. Okay? Specifically in this slide, tsaka on the next slide. Okay? And just take note of the differences. Okay? Characteristic differences. Basta may systolic failure, diastolic heart failure. Okay? Now, moving on, let's talk about the different mechanisms of heart failure. In the compensatory mechanisms of heart failure, alamin natin bakit nga ba progressive condition ang heart failure. Bakit siya progressive? Okay? Progressive because part of the action being done by the body to address the problem, di ba, is to compensate. Kaya lang, ang problema, because of that compensation, mas lumalala ang kondisyon ng patient na may heart failure. Okay? So we have here a vicious circle, okay? A vicious cycle that explains how the heart failure progresses. Okay? How the heart failure progresses or paano siya lumalala. Okay? Lumalala kahit may compensatory mechanisms. Okay? Of course, ang major problem sa heart failure is that yung heart does not contract well. Diba? Heart failure nga. The heart does not contract well because of myocardial injury. Again, because of myocardial injury. So kapag hindi nagpa-pump ng maayos ang puso, chances are lesser talaga yung ventricular performance. Okay? Lesser yung ventricular performance. Okay? Kaya, kung lesser yung ventricular performance, hindi masyadong nagko-contract properly yung left ventricle to pump out its contents ng heart, okay? Ano yung mangyayari sa amount ng dugo na naipapamigay, okay, sa parts ng katawan? Kaya, ang mangyayari, yung amount ng dugo na naipapamigay sa iba't ibang parts ng body, okay, or yung, di ba pag amount ng blood is, then yung cardiac output. So, ang nangyayari sa cardiac output is lesser or lower. Okay? Lesser yung amount ng dugo na naipapamigay sa different tissues ng body. Kasi nga, yung ventricular performance, lesser. Okay? So, ayan. Remember, sa heart, sa hypertension lecture natin, kapag konti lang yung amount ng blood being pumped out or ejected by the heart, or kung konti lang yung cardiac output, that triggers compensatory mechanisms. That triggers compensatory mechanisms. Ibig sabihin, konti lang yung example, pag konti lang yung amount ng blood, say for example, na nasusupply sa renal, okay? So, may renal, low yung renal blood supply. Probably, ma-activate yung RAAS. Diba? Pag may renal, low blood supply sa renal, okay, sa kidney. Also, in some cases, kapag mababa ang pressure, nagkakaroon din ng baroreflex activation. So, yun yung mga compensatory mechanisms. But yung common dito na nangyayari na mechanism is the neurohumoral system or mechanism. Okay? Again, ang common dito na na-activate na compensatory mechanism with low amount of blood being pumped out to the different parts of the body, low cardiac output, na-activate yung neural mechanism, increasing sympathetic activity. In short, kapag may enhanced sympathetic activity, okay, example, may sympathetic activity like beta-1 activation. Beta-1 activation that triggers RAAS. Tama? Diba? Isang trigger yon for RAAS. Halimbawa, so nagkakaroon ng vasoconstriction at saka fluid retention. Okay? In which, kung naaalala nyo ang relationship kapag may vasoconstriction, kapag may fluid retention, that increases the workload of the heart. Kasi may increase yung fluid retention, increase yung blood volume. Okay? May vasoconstriction. Okay? That increases the workload of the heart. Bale, nagkakaroon ng enhanced burden sa puso. And with enhanced na demand of the heart, enhanced burden, okay, it will enhance further the injury or the severity of the injury. Okay? Ma-enhance yung myocardium injury in the heart. Okay? And because of this injury, less volume na naman, okay? Then compensatory mechanism again, retention again, kaya cyclic na nangyayari. Cyclic siya. So, paulit-ulit siya. Kaya nagiging progressive. Okay? Yung state kapag may heart failure. Okay? So, to be able to discuss it further, bakit lumalala ang heart failure, discuss naman natin ngayon ang iba't ibang compensatory mechanism starting on neurohumeral mechanism. Okay? So, di ba, isa tong compensatory mechanism during heart failure. Now, sa neurohumeral mechanism, okay, there are different compounds being secreted by the body. There are different compounds being secreted by the body to be able to address the problem in heart failure. So initially, di ba, compensatory mechanism nga, good thing siya. Initially. Okay? Initially, it is something good talaga. But since repetitive ang nangyayari, pwede niyang mapalala ang kondisyon ng puso by increasing the burden or causing, yun na nga, further myocardial injury. So number one, part of neural compensation is, yun na nga, yung RAAS activation as we have discussed. So RAAS activation, that is by enhancing angiotensin 2 synthesis. So kapag enhance ang angiotensin 2 synthesis, what must be realized? Mayroong fluid retention. And also, other effects could enhance BP, di ba? Therefore, enhancing burden sa heart. Also, we have endothelin release. Ang endothelin, na-mention ko siya under vasodilators sa hypertension nga lecture ko. Endothelin, kung naaalala nyo, this is a potent vasoconstrictor. Okay, potent vasoconstrictor. Okay, so kapag may release, may secretion of endothelin, that further enhances burden sa puso kasi vasoconstrictor siya. It causes vasoconstriction. Okay, so that further enhances burden sa puso din. And then, sympathetic stimulation, related din to sa mga na-discuss nato sa previous topic. 'Di ba? Yung mga effects kapag may stimulation of sympathetic effects that could increase BP. So, burden pa rin sa puso. Okay? And then, yung natriuretic peptides like the brain, natriuretic peptide. So, the figure below, itong figure below, this explains the declining of cardiac performance. Again, yung figure below, this explains the declining of cardiac performance whenever there is continuous secretion of these different compounds discussed earlier. So, 'di ba, ang initial trigger natin sa neurohumeral mechanism is yung myocardial injury. Okay, yan yung initial trigger sa neurohumeral mechanism, myocardial injury. Therefore, pag may myocardial injury, lesser yung ventricular performance, thus decrease yung cardiac output. As part of the compensatory mechanism, itong mga substances na to or compounds like norepinephrine, angiotensin 2, endothelin, okay, it will be secreted. Okay, it will be released. Okay. Now, ang effect nito due to uh, burden is enhanced na afterload. 'Di ba? Ma-enhance ngayon yung afterload. Kasi nga, due to burden na dala-dala ng mga compounds na to. Okay? So, enhance ngayon yung SVR, yung afterload. 'Di ba? Pag enhance afterload, it tells something about greater effort ngayon yung heart, greater pressure, greater contraction is needed for ejection to happen. Di ba? Pag-increase after load. Okay? Kailangan dapat ang puso mag-contract greater kasi enhance daw yung SVR. So, greater pressure ang needed para mailabas ang dugo. Kaya nga lang, ang problema, heart failure. Diba? In the first place, sa heart failure, mahina mag-contract ang puso because of myocardial injury. Kaya still, mababa yung ejection fraction. Okay? 'Di ba? Taas yung afterload pero konti lang yung nailalabas. Kasi nga, the heart fails to contract well. Okay? Kapag mababa ang ejection fraction, decrease yung cardiac output. So, trigger na naman yung release ng mga active endogenous substances, kaya tataas ulit yung afterload. Okay? So, as time passes by, okay, ayan, as time passes by, because of these continuous compensatory mechanisms, the cardiac performance diminishes. Okay? The cardiac performance diminishes. Now, another compensatory mechanism wherein during heart failure, kapag ang patient may heart failure, is yung hypertrophy. Okay? Hypertrophy wherein the heart muscles enlarges due to remodeling. Okay? Nagkakaroon ng structural changes sa heart, and that is because of death of some cardiac muscles caused by ischemia and enzymes like caspases. Okay? That also causes cardiac cell death. Okay? Then we have remodeling. It means dilation naman and other structural changes that occur in the stressed myocardium. So such structural changes or remodeling in the structure of the cardiac muscle that affects the amount of the blood being ejected by the heart. Kaya, connected again sa vicious cycle na na-discuss kanina. Okay? So, yun yung nangyayari kapag may mga compensatory mechanism. So, at first, okay siya. Okay? It offers something good. Pero kapag repetitive na, lumalala tuloy yung heart failure condition. So, taken all together, those are the important compensatory mechanisms. Okay? Now, let us continue to be able to assess clinically the patient with heart failure. Maraming mga organizations, associations that establish different classes of heart failure patients depending on the manifestations na nararamdaman ng isang pasyente na may heart failure. So we have two organizations that established different stages or classes of heart failure. So yung first guideline, ayan, is based on the New York Heart Association. Okay, New York Heart Association. Actually, just you can just read this out and check this out. Ang point lang nito is when the class number, okay, ito, yung mga class number or stage increases, the more severe is the condition. Okay, for example, sa class 1, okay, class 1 na classify yung patient na may heart failure. Wala pa siyang nafe-feel na mm, fatigue, okay, or dyspnea or palpitation. So, wala pang nafe-feel na symptoms, okay, yung patient. Kaya, walang limitation ang involvement niya sa physical activity. But on class 4, kapag class 4 na, as you all noticed, okay, as you all noticed, even the patient is at rest. Even the patient is at rest. Okay? The fatigue, dyspnea, okay? Yung palpitation feels, okay? These symptoms still occurs even at rest. Okay? So, mas malala ang class 4. Sobrang lala na siya. Okay? Then, another guideline classification was established by American Heart Association, American College of Cardiology. So, ACC, AHA. Okay? So, yung ACC naman, or AHA, they establish different stages naman. Okay? Different stages from stage 1 until stage D. Okay? Unlike ang NYHA, yung New York Heart Association na guideline classification, yung classes nila is 1 to 4 ang pangalan. So, dito, stages is A to D. So, you just read this, check this out, and please observe the symptoms per stages. Kung ano yung nangyayari sa patient per stages or per classes.